All right. Good afternoon, everyone. Welcome to our next session in our Boosters and Beyond Addressing Key Challenges series. As you know, we've been going through the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. This week, we have Mary Ellen Casey going to be talking to us about reprocessing of reusable medical equipment. Before we get into that, we want to make sure that we go through our typical action items at the beginning of each session. So if you're not familiar with who we are the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract for the regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO. So if anyone asks if you're working with IPRO or if you know who IPRO is, you say yes. Next slide, please, Mary Ellen.
And with that, I guess I'll get started, Josh. Thanks so much. Good to have everybody on the call. So we start with our COVID update, and hospitalizations continue to trend down, which is great. Bivalent booster continues to tick up in the right direction. We're almost at 42% of adults 65 and older with an updated bivalent booster. The variants have not changed. It's consistently been XBBB strain at 96% with little change, which is good news. And we remain at 53% of nursing home residents that are up to date on COVID-19 vaccines, according to the NHSN data. So that work continues. So we're going to dive right in. The learning objectives for today's session are to discuss key principles for reprocessing medical devices and equipment, apply the Spaulding's classification of medical devices to determine that level of reprocessing that's necessary, look at some quality control measures that ensure safe and effective reprocessing, and then explain criteria for proper equipment maintenance and clean and sterile supply storage. So a lot of information to get to. Some I will go through quickly, and others we'll spend a little bit more time on. So just as a reminder of what that CDC core principle is in regards to reusable medical equipment. It's to clean and reprocess equipment prior to use on another resident or when soiled, that we maintain that separation between clean and dirty equipment to prevent cross-contamination, that we're using manufacturers' instructions for reprocessing, that we're training staff on that those instructions are posted and available, that we're using PPE necessary for the task, and that we have competencies for those personnel that are trained in these kinds of duties. So we'll dive into a little bit more of what that criteria means with this presentation. So reprocessing will vary according to your setting, but the principle of reprocessing is the same. Residents expect that medical equipment used or involved in their care will not cause them harm. It's really easy to inappropriately reprocess medical device equipment, leaving behind microorganisms. I'm sure we've all heard horror stories of how that can happen. So reusable equipment has to be reprocessed according to manufacturer's instructions, standards, regulations, best practices, and manufacturer IFUs are really the minimum as far as what needs to be done for reprocessing in order to meet best practice standards and guidelines. So that's important to remember that it's just, it sort of lays the foundation, the IFUs, but there's so much more to it depending on what your requirements are and what you're doing in your facility. So the goals of safe reprocessing, they apply if it's done within your facility, but also the facility is responsible for any medical devices that are used to provide care in their facility. It could be dental equipment or external podiatry services. Equipment is delicate. It can be easily damaged and costly to repair or replace. So that's the other piece of it, that you want to make sure that the equipment is properly functioning and not still being used if it's damaged, because there's an additional risk for that. So we want to prevent transmission of microorganisms to personnel, to residents, and minimize damage to that medical equipment or devices. Staff education is another key principle. It's important regardless of the setting. And in long-term care, it's particularly challenging because if you are a facility that's involved in reprocessing, your staff needs to be trained in it. And also those staff wear a lot of hats. Traditionally in long-term care, it's not just one job or responsibility that you have, there are multiple hats. And so that makes it even more of a challenge. So you need to identify and determine which staff will carry out the responsibility and make sure that they are trained. Single-use device, I teased out a little bit because this should not be reprocessed or be reused. Certainly with the pandemic and the crisis standards that came out, there was a lot of variation because of supply shortages. And so there were some temporary instructions for use for equipment that you wouldn't typically in normal times use repeatedly. So I just want to emphasize that it should not be reprocessed or reused. You may be involved in purchasing of equipment at your facility. I hope so. I know that's always a battle for the infection preventionist to be at the table, but this is one of those areas where it's really important that the infection preventionist is aware of what kind of equipment is coming in, that they can do an assessment to become familiar with the equipment so you can anticipate what the reprocessing is going to look like and what needs to be done. And certainly when facilities are looking at the cost between single use versus multi-use, that there's a lot more to consider than just the initial cost. It's staff time, education, the equipment. Are you going to be reprocessing it? Is it going to be done by a third-party vendor? How are you using it? So it's a lot to think about, and it's important to be at the table for those discussions. We talked about manufacturers' instructions. They need to be available to staff who are responsible for reprocessing. Again, it's considered to be the minimum standard, so it's a part of your toolkit. They should be periodically checked to ensure there have been no changes. And ensure that items that are being reprocessed are not labeled single use. I can't tell you how many times just preparing for surveys and going around to the departments and finding out that, oh, we've been using this a couple of times, we've been wiping it down because there's been a supply shortage with it. And so unbeknownst to the infection preventionist, they may be doing things that they shouldn't be for a lot of reasons that you're not aware of. So you might consider a binder for instructions. You might have a system where you can look it up online, which is always helpful because if it changes, you have the most up-to-date and you don't have to spend your time updating outdated IFUs. Policies and procedures are important and should follow those regulatory requirements, reprocessing standards, those best practices. These again should be reviewed by an infection preventionist to make sure that they align with the criteria that's required. Reviewed annually when there's a change in process, when there's new equipment. So it's a very timely process even to be on top of it. And the policies and procedures should be available in areas where reprocessing takes place. And if you don't do it in a place where people who are overseeing it can easily access it. So we hear this an awful lot, that cleaning and disinfection are one and the same thing, and they're really not. And what is that difference? You know, when I think of cleaning and disinfection, I think of a peanut butter and jelly sandwich, because together they do wonderful things, but they're very distinct and different. And so cleaning is the physical removal of dirt, blood, body fluids, and other organic matter. It's accomplished by a combination of detergent, water, and applied friction. It does not mean that a surface is free of pathogen. It merely reduces the number of those pathogens to the point at which their presence is unlikely to cause harm. So for that reason, a clean surface cannot be presumed to be disinfected or sterile. Likewise, with the disinfectant, a surface can't be disinfected unless it's clean. So disinfection destroys the number of potential pathogens on a surface. So cleaning kind of gets it ready for the disinfection process, and that process kind of swoops in. So a surface cannot be disinfected unless it has been cleaned. Disinfection is most commonly done using chemicals approved by the EPA. You may be a facility that uses alternate methods. There's so many different types of methods, some more costly than others, but you may have heard of things like ultraviolet light therapy or disinfectant fogging can be used. But the bottom line is that no matter what process you're using with disinfection, organic matter, such as blood and body fluids, will inactivate disinfectants. So you really have to prep that area in order for the disinfectant to work like it's supposed to. So organic matter has to be cleaned prior to the disinfection. Different disinfectants will kill specific type of organisms, and we've talked about that in other sessions with environmental cleaning, but they don't produce sterility. No matter how strong that disinfectant is or how frequently you use it, it's not sterile. So it's just important to remember that these are three distinct categories of reprocessing. So some of you on the call may be very familiar with the Spaulding classification. Some may not have heard of it. And hint, for those of you who are thinking about taking the certification exam, they ask a lot of questions about this. So what is it? So Dr. Earl Spaulding, he was a microbiologist in Philadelphia. He wrote this landmark paper in 1938 that proposed an approach to disinfection and sterilization as part of patient care items. So he was trying to move it out of that surgical suite mentality. And that became known as the Spaulding criteria, and it was created in 1957 to determine when reusable medical devices could be disinfected or sterilized based upon their infection risk. So here's an example of a Spaulding classification tool for medical devices. And you can Google this tool and get it in all kinds of formats. So what I did for this presentation is I added a column for the application in long-term care facilities. So recognizing that we're talking about reprocessing, and many of you probably don't do sterilization or high-level disinfection, but you need to be aware of it because there may be third-party vendors coming in offering services in your facility that are doing it. And so it's good to have that knowledge of what it entails. So the tool is divided into three categories based on the type of contact the device has with the resident and the risk of infection. So there are three classifications. There's critical devices, semi-critical devices, and non-critical devices. And we'll go into a little bit more detail on how they're used in resident care. But here are some examples that might be familiar to people. For critical devices, surgical instruments, that's obvious, but podiatry instrumentation is also considered a critical device. And certainly podiatry services are a part of long-term care facilities. So it's important to know that they need to be disinfected through sterilization. Sterilization process in the long-term care facility, very uncommon. Semi-critical device classification involves things like dental instruments or vaginal specula, ultrasound probes where it's intracavity. Now, a lot of these procedures, folks may be going out to have them done, but oftentimes, particularly with dentistry, they're coming into the facility, and this requires high-level disinfection. And so some facilities, depending on the level of service they provide, may be performing high-level disinfection. So some of the things just to consider, and we'll talk a little bit about this, is what do you do with the instrumentation before it leaves the facility? And that may be something that the vendor does themselves, but certainly something to be aware of, and we'll talk more about that. Non-critical or low device classification is probably what long-term care facilities are most familiar with. And this is low-level disinfection, cleaning and disinfection, particularly using wipes. That's the most common that you would use for things like blood pressure cuffs or stethoscopes, patient lifts or point-of-care devices, things of that nature. So we'll dive into each of these briefly. The critical medical device, they are devices that are used that enter the sterile parts of the body, such as the blood vessels, which are considered sterile spaces. So one of the reasons that intravascular devices are considered sterile, they need to be cleaned and sterilized. So an example is, as I mentioned, foot care equipment. These instruments need to be pre-cleaned, cleaned, and then sterilized in order to receive that outcome of sterilization. And so pre-cleaning is, a slippery slope. And if you think about it in your own facility, I know from my own experience, podiatry is a challenge. This is usually the area where we're most trying to turn the Titanic, if you will, because these instruments are delicate, they have moving parts. So when you talk about pre-cleaning, the instruments need to be open. If they're scissors, they need to be opened, or biceps or forceps, or all these things that they're using need to be opened and pre-cleaned. So that may be using a solution that you spray on the instruments in a basin prior to them leaving the facility. And the goal of that is really to limit the bioburden from turning into cement. So there's bioburden on these instruments, and if it's left just to sit somewhere and dry, you literally have to chisel it off before you can even clean it. So certainly surveyors, if they're looking at reprocessing, they go right to the basin, they make sure all the instruments are open, and then everything is sprayed or moist before it's sent out, or it goes on to the next step of cleaning and sterilization. So something just to keep in mind, that it's a real process before it becomes sterilized. Semi-critical medical devices are those that come into contact with non-intact skin or mucous membranes but do not penetrate them. And an example would be dental instruments. And again, they would need to be pre-cleaned. These instruments, I'm not as familiar with if they have any openings or mechanisms that you have to open them, but they need to be pre-cleaned so the bioburden doesn't harden again and really derail your high-level disinfection efforts. And the outcome is for the instrument to become disinfected. High-level disinfection involves a lot of steps, and again, recognizing that a lot of facilities don't do high-level disinfection, but you need to be aware that there are certain processes that have to be followed with high-level disinfection. We know that it eliminates vegetative bacteria and envelope viruses as well as non-envelope viruses. Most high-level disinfection that facilities see is achieved through liquid chemicals. Pasteurization is something that's done a lot with respiratory equipment and anesthesia equipment. So chemicals are typically suited for instruments. And it's not only the process of doing the high-level disinfection, you also have to monitor it for safety. It has to be documented, it has to be audited. The chemical concentration itself has to be checked and verified using test strips. This is another example of following manufacturers' IFUs, because you want to make sure that the equipment that's being dunked into this chemical solution is actually working. And so it must be compatible with the items that you're actually disinfecting and cleaning. It has to be diluted properly in some cases. It has to remain in contact with the medical device for the required period of time and rinsed appropriately. And this gets challenging. I can remember working in a facility where they were using vaginal probes quite often. It was a women's specialty hospital, and so that device was used constantly. So they put it in the high-level disinfection, and then they forget about it. Well, guess what? When you pulled it out, it looked like Papa Smurf. That's what we used to call it, because it turned it blue, and it was not usable after that. So it became a real problem having someone there to monitor. Okay, it has to be in there 12 minutes. You got to stay here 12 minutes and make sure you take it out, or else it's cooked. And then proper PPE is required. I mentioned the chemical test strip. So again, part of that process is a constant quality assurance procedure, and that determines whether the concentration of active ingredients is present, it's actually working. You need to test the disinfectant daily and follow those instructions. It has to be checked every time you open a new package or bottle to verify it's accurate. So it's similar to the quality assurance that you would do on a glucose monitor. And again, it's time consuming and tedious with all the steps involved. You cannot justify using a chemical beyond its expiration date if you take a chemical test strip that's within its user appropriate dates and dunk it in a concentration and say, oh no, it passed the test. If the solution is expired, it doesn't matter. The chemical strips can't be used in it. So it's all those things that are so important to make sure that high-level disinfection is actually working properly. And if you use a third-party external company for reprocessing, these are a lot of the things that you need to keep in mind. You may not be doing this type of reprocessing in your facility, but you want to make sure that your third-party vendor is doing what they need to do to reprocess it properly. Non-critical medical devices are equipment that touches only intact skin and not mucous membranes, or does not directly touch the patient, using an example of a wheelchair. This can get a little, you can get a little lethargic with this, if you will, because even though these items are a lower risk for causing infection, they can still pass on microorganisms. And the bulk of long-term care equipment really falls into this classification. And even though the cleaning and disinfection requirements are less stringent than the others due to the amount of equipment, it really requires a lot of attention because it's so much. And, again, we've talked about pandemic fatigue and PPE fatigue, cleaning fatigue is real. It's sometimes you don't even think about it because you're just running from one thing to another. So I think that's one of the biggest challenges for long-term care. You have a lot of it. And you have to remember that outbreaks are not uncommon with these types of devices. We're going to talk a little bit about that later on. You may have a process where you use a one-step cleaner and disinfectant, which is helpful because it helps with time management and such. Or you may have a process where you're using a cleaning product and then followed by a disinfectant product. So there's a lot of detail with it, a lot to consider when you're on a committee reviewing these products, and certainly the Spaulding criteria table can help with your assessment of what medical devices you have and what's needed. Other non-critical equipment to consider are personal items, and although we don't talk a lot about this with reprocessing so much, they are considered single device use, obviously. But things like electric toothbrushes and electric razors, they are single resident use only, and they should not be shared due to the risk of bloodborne and other pathogen transmission. And when possible, if you can put an identifier on them, that's really helpful. I certainly know this is easier said than done. When you think of the population in long-term care facilities, particularly folks with dementia, this is really challenging. And I always, getting ready for this presentation reminded me of my dad, who was in long-term care with dementia, and he had such a fixation with electric razors. It still blows my mind. So I think I bought out Walmart for all their electric razors because I used to bring them to the facility and leave like 5 or 6 of them at the nurse's station because he was forever taking them apart. He would hide them places. He would go into other residents' rooms and take their electric razors. So it's certainly something that you could chuckle over, but it's a real problem and certainly hard to control. So just something to consider. I love this slide, and I stole it shamelessly from Bernie Miller, who did the environmental services session, which was so great a few weeks ago. But it's just a reminder as part of all this that there is a hierarchy to cleaning. And so some of these organisms fall on the lower end at the bottom where they're easier to clean, and then scale up to bacterial spores, which are the hardest to clean. So it's also something to keep in mind, not only with product selection, cleaning and disinfectant selection, that you want to think about that hierarchy too as you're choosing products. Another part of reprocessing that's key is quality control measures. Every long-term care facility should have a system in place that allows for the provision of cleaning and disinfection and sterilization if that's something that you're doing. From an administrative perspective, there needs to be policies and procedures and properly functioning equipment, that there's access for staff to review current guidelines and standards and IFUs and keep up on that because it's ever changing. And if you do reprocess, that you set up a good workflow where there's established clean and dirty areas. One of the other things is, to think of is, what kind of equipment to support your reprocessing efforts if you're doing that. If you're doing reprocessing, the indicator monitoring, that you have the equipment needed to do, whether it's sterilization or high-level disinfection, having those monitors in place to make sure that it's safe and effective. Documentation, that's key to everything, right? So if you are doing high-level disinfection, you should be keeping a record of it or a log. Surveyors love to come in and see if there's gaps in the documentation. If it's something that you can reprocess 3 times a week, that's fine, as if that's what the manufacturer's instructions say. However, you need to follow that schedule. And so however it's done, that you're putting the proper information and doing it per manufacturer's instructions is really important. Continuous improvement also involves auditing, and we talked about this in terms of you may not be doing reprocessing, so why do I even need to know about this? But if you have a third-party vendor, these are some of the questions you might want to ask them. Does their reprocessing meet standards? How do you know that? What are they reprocessing? Are their staff trained? Are they certified? How do they store devices? And that's something you may want to audit at your own facility, because what are you doing with the equipment before it goes back out to be reprocessed? So those are all questions that you need to think about, even if you're not doing the direct hands-on reprocessing. Maintaining equipment is another key area of reprocessing, and we don't talk a lot about this when we're talking about cleaning and disinfection. What happens after you do that? And so when you're maintaining equipment, you need to think about essential infection prevention elements. Certainly, immediately cleaning and disinfecting the equipment with a facility-approved EPA disinfectant is very important when visibly soiled or right after use. Another thing is to verify that that disinfectant safety data sheet is on file at the facility and readily accessible. The safety data sheet, if you've never seen them, they are required for a facility to have on hand, whether it's online, which is sometimes better because it updates automatically, versus a paper copy of it where you're kind of responsible for making sure it's up to date. But it tells you the ingredients of the disinfectant, how to use it, it tells you the PPE to wear, and it tells you what to do in the event of an exposure. So they're really important. And then once the equipment is cleaned and disinfected, clearly identifying it. This is challenging, especially when you're space compromised. In a perfect world, we'd all have these clean rooms and dirty rooms and properly labeled, but this has been a challenge. And so there needs to be a way to identify what's been cleaned and disinfected and ready for use, whether you use a tag or a label. There's been some creative mechanisms to do this. A dust cover, a plastic bag, a room that has a sign on it that says clean equipment only, anything that really helps to identify the difference between your clean and dirty equipment. The equipment policies should contain essential infection prevention elements, that you're following those manufacturer's instructions, that you're monitoring the staff and they're following the EPA recommendations for that wet contact time, which is challenging, again, depending on your product. You could be looking at a product that has to stay wet for 12 minutes versus maybe a product that might do the same job in 3 minutes. So certainly whatever your product is, that they're following and they know that contact time. Discourage application of tape to equipment, because equipment with tape residue is not considered clean. I have gotten dinged on this almost every survey I've ever been involved in. Sometimes that residue looks like bioburden. It's really gross, but that is a low-hanging fruit when you're putting tape, and it's easy to label stuff with it, isn't it? But it's really not something you should be using. So discouraging it is really important. We always talk about PPE and the appropriateness of using it. Particularly, I get on my soapbox about goggles, but a lot of this cleaning and disinfection involves chemicals, so a splash exposure is not uncommon. If you're reprocessing, eye wash stations that are located close to where that's being done, but really with EVS services, they're using chemicals for cleaning that an eye wash station is important to have close enough so they can get to it in the event of an exposure. Storing clean equipment and clean sterile supplies, so many things to consider with this, particularly when you're, all the time, but it always comes up when you're preparing for a survey. How to store sterile disposable items. And there's a whole bunch of criteria in terms of the distance from the floor, the distance from the outside wall, that you're trying to protect it from exposure to the elements, particularly moisture, heat, temperature extremes if it's in sunlight, not to be near windows. With sprinkler systems, you need to have them at a distance from the sprinkler head to be in compliance with fire code. So that's something you have to consider. Don't prop open the entrance door to the sterile or clean supply storage room. A big no-no. It happens so much. And one thing that we get a lot of questions, I see a lot of questions on different listservs about this particular topic, is clean and sterile disposable products that arrive at your facility in a shipping container. So to ensure maximum cleanliness during storage, you should remove the shipping container prior to placing the supplies in the clean storage room. The boxes or the soft packaging within that cardboard are considered clean. So you may have a process where it might come to your facilities department. Maybe they could load it on something else and bring it up. But having corrugated boxes is an infection control no-no. So they're considered dirty and they're considered risky for transference of pathogens and critters too. That's another consideration. But so once they come out, the packaging inside that box, you can put in your clean utility room, no problem. It's just getting it out of that. You can't put the cardboard box in the room and just leave it there. Other things to consider too that has happened is don't leave trash or fluids on the floor in these clean utility rooms. Another no-no, certainly something surveyors will look for. Additional considerations is to have a stock rotation procedure in place, not keeping things under the sink, having a physical barrier between a bottom shelf and the floor, and that's for splashing from house cleaning when they're cleaning the floor. Rented equipment is a particular concern because if you're renting equipment like pumps and tube feeding pumps, and it's really easy to want to keep them handy instead of returning them to the place of origin. But that place of origin is responsible for that reprocessing, and they may have instructions that need to happen with those particular pieces of equipment that you don't necessarily have access to. So something to consider. And nebulizer equipment, again, there's single-use components to it. The machine itself may be shared between residents and needs to be cleaned in between per the manufacturer's instructions. I know we're running overtime and I'm just going to run through this really quickly, but I wanted to give a perfect example of reprocessing and all that it entails. And this is a blood glucose monitor, which is low-level disinfection. So just consider that because long-term care facilities use this a lot, particularly because they have so many residents that would require assistance with monitoring and insulin administration. So outbreaks of hepatitis B are associated with blood glucose monitoring, and it's been increasing, particularly in long-term care settings for the reasons I mentioned. And over the past 20 years, there have been at least 15 outbreaks of Hep B associated with providers failing to follow basic principles of infection prevention and control. And the CDC feels that this number is underreported because oftentimes you don't know if Hep B is occurring in your facility as a result of this. And certainly infection control practices involving equipment and supplies, including never reusing certain pieces of the equipment, changing your gloves, hand hygiene, cleaning and disinfecting that blood glucose meter is so important when equipment is shared. So, I list this because long-term care has a really important role in this because of the amount of low-level disinfection you're doing and the fact that, we're seeing these outbreaks with this type of equipment. So certainly something to be cognizant of. And with that, I have the resources listed, just a list of some of the resources we've used. This one in particular, if you go to this website, has so many topics on sterilization, disinfection, cleaning, and some that would be very relevant for long-term care, as I had mentioned, dentistry, low-level disinfectant. Take a moment and check it out. There's a lot of information to help guide you. And with that, if there's questions or comments, Josh or Darlene, any thoughts? Happy to take questions.
So there was a comment into chat. Margaret shared that we have a separate glucose monitor for each resident here. We do still clean them, but we don't share them.
I mean, obviously that's ideal, and I'm sure the cost and all. But when people push back with cost, I always say, what's the cost of having the news reporter outside your facility, talking about how you cause an outbreak because this, that, and the other. I know it's not always feasible, but that is ideal, and certainly we promote. But it is very cost prohibitive. But kudos, that's great.
Not seeing anything else in the chat. Margaret, she did have a question about a link to the Addressing Key Challenges page. I can follow up with you via email to that, Margaret. I don't have that in front of me at the moment. But Brooke shares, struggling with long-term care, holding on to multiple use single patient items and a corrugated cardboard.
What is it about cardboard? I feel your pain. Yeah, I mean, I guess you're a constant nudge. That's how and with evidence in hand to say, look, this just goes against every infection prevention guideline out there, and for a lot of reasons. But kill them with evidence, I guess, is my mantra. But it's very challenging to have those conversations when people, I don't know, they have differing opinions about that.
So I'm not seeing anything else. Please reach out to us if you have any other questions. Our contact information was shown there. We are having a live replay of today's session tomorrow at 3:30. So if you know anyone who would benefit from today's session, please encourage them to check out the recording tomorrow at 3:30. And then we have our IP3 session, of course, this Thursday at 11 a.m. That would be it for today's session. If you thought that today's session was helpful for you, beneficial, worth your time, please let us know in chat on your way out. It does really help inform us of which content is our topics that you all are looking for. So thank you so much.